Hi everyone, I'm Neil Shore. I'm the Medical Director of Carolina Urologic Research Center. It's a great pleasure for me to talk with you today about my experience with patients with advanced prostate cancer. I want to share with you a couple of stories of patients with prostate cancer whom I've treated or I've been involved with their care, and how do we think about optimizing their care. So many things have happened in the advancements in the trial landscape and the category A or level 1 evidence for improvements in how we optimize patient care, specifically with advanced prostate cancer. And we'll break down the differences in what I'm referring to in advanced prostate cancer. But before I discuss some of the most recent and cutting edge data that I think really should reframe, reshape how you treat prostate cancer, I'd like to let you hear from a patient. And this gentleman has had a really profound experience. Because of his experience and his diagnosis and the things that he's thought about in discussing his care with his physician and the physician team, which includes clearly also other healthcare providers, advanced practice providers and nurses, it's important because it really has us optimize that physician-patient shared decision-making, which has become somewhat of a mantra over the years. And I think it's important because it makes us all better communicators. And so we'll show that video right now.
My name is Tom Reminick. I am a prostate cancer patient. I have been diagnosed with prostate cancer at a somewhat early age. I was 54 at the time. I'm currently 65. So I have been with prostate cancer for 11 years now. I've gone through the various treatment stages, that is prostatectomy, radiation, and I'm currently on hormonal drugs at the moment. It has been a long time that I've had this. I've been constantly aware of the cancer and what I have. My wife has probably taken the biggest brunt of the disease, but fortunately I'm, other than the cancer, I'm in a healthy condition. So it really has not had too much of an effect on the rest of my family. I do have 2 children that are grown and are not really in the area. But other than that, I'm a reasonably healthy person, but always constantly aware of the prostate cancer that I do have. The educational discussions that I do have with my physicians actually have been fairly numerous. But it really occurred in the latter stages of the disease progression. My initial diagnosis and initial treatment, which was the prostatectomy, I'll admit I was fairly ignorant. I thought that would be somewhat of a one and done treatment. So I didn't have a lot of educational resources at the time or felt that I really needed it under the belief that I was probably going to be done, completed with the disease after the surgery. That was not the case at all. It actually, as I had mentioned before, this has lasted 11 years, and as I've progressed through the various stages and the different treatment stages, I've spent a large amount of time on the aspects of education, learning about the disease itself, as well as the various treatment options that are available. One of the factors that contributed to engaging fully with the healthcare team, primarily the physician, was education. My understanding of what the treatment would be or the treatment options and some of the mechanisms of action were tremendously beneficial to know what that was and how those operated when I did talk to the physician about what my treatment may be or what options that there may be. I think if I did not have an understanding of that, it would have been more of a one-sided conversation, and I really wouldn't have maybe fully understood the options that he presented to me. This way, with some research on my part and understanding of what was out there and what was possible, and sometimes I would even identify options that he did not bring up, but nevertheless, by asking the questions, the physician certainly answered those questions, and I think that helped show him that I was truly interested, I was truly engaged, and that we could have a dialogue on the subject versus kind of being just dictated to and telling me what the treatment option would be. For any patient that is newly diagnosed with prostate cancer, I would have some recommendations that I would give them. In fact, I have. I've had two friends of mine have recently been diagnosed with prostate cancer, and these are some of the words that I passed along to them. And number one is education. Learn everything that you can about the disease, and not only about the disease, but what your treatment options are. Learn what those are and have that discussion with the physician, and that is key to your ultimate treatment with the prostate cancer. Learn about that. The other thing I would tell them is that I have told them is that you're in for the long haul, that this disease does not go away simply as a result of a surgery or simply as a result of radiation treatment or hormone treatment, that all that does is really it just suppresses it, and that you might as well get used to the fact you're probably going to be with this basically for the rest of your life. One of the questions that I wish I had asked at during my initial diagnosis and treatment was an understanding of the total timeline of the disease. At the time, myself and the physician, we were really focused on the immediacy of the treatment. Initially, it was the immediacy of the surgery. Later on, it was of the radiation treatment. But I think it would have been very helpful if the physician was able to describe the timeline of events and how the disease does or sometimes does not progress throughout the rest of your life. That prostate cancer really sticks with you for your entire life, and it's good to have an understanding of how that's going to work through your life. That once the surgery is done, it's not necessarily over. Once the radiation treatment is done, it's not necessarily over. But I never had a good understanding of the entire timeline of how the disease could potentially progress. And I think that would have been very helpful if I knew that during the initial diagnosis or some of the initial engagements with the physician.
So Tom's presentation and his commentary is really similar to many of the comments and feedback that I receive in patients within my own clinic. Tom's comments, and oftentimes the caregivers as well. It could be the spouse, it could be a partner, it could be a family member. I think this is really important for us as we do a better job of understanding what patient concerns are. But regardless of the stage of disease, whether it's newly diagnosed or metastatic newly diagnosed or recurrent metastatic or castration resistant, this concept and the importance of shared decision making is absolutely essential for earning patient trust, to better guide their care, and to optimize how well they do, how they can live longer and live better. We all know that prostate cancer exists along a significant continuum, this prostate cancer journey that we talk about. The prostate cancer journey has been divided up by clinical disease states, and I think that helps us sort out in our own mind how we approach the different therapeutic options. Certainly we diagnose patients early on with localized disease. We want to cure them with surgical removal of the prostate or radiation therapies. And we do a great job, but unfortunately, anywhere between 15 to 30% of patients will fail our initial active treatment strategy. Some patients will also present with metastatic disease and really don't afford the opportunity to do an interventional treatment. So there's sort of two buckets of patients. There's the patient that undergoes an active treatment, surgery, radiation, possibly a focal therapy, then develops a rising PSA, and at a certain point in time, we decide to institute testosterone suppression, or oftentimes referred to as androgen deprivation therapy. Then we see PSA declines, but invariably it's not curative. And so at a certain point in time, the PSA rises, and if we're vigilant about doing imaging, we may catch that rise before we see positive imaging. I'll talk more about that later on. That would be the category non-metastatic castration-resistant prostate cancer. Now, going back a second to newly diagnosed patients with prostate cancer who have disease outside the prostate by conventional imaging with CT scans and technetium bone scan. They may have bone disease, low volume, high volume. We'll talk more about what that definition is. But also they could have disease demonstrated in soft tissue, typically nodal disease, or even visceral metastases, liver and lung disease. These patients then also benefit from systemic therapy. And that's what I'm going to first talk about today, and how things have changed dramatically and how we approach these patients who have what we describe as de novo metastatic a castration-sensitive prostate cancer. And some of these patients will have what we describe as recurrent metastatic castration-sensitive prostate cancer patients. That patient group coming from those who failed surgery, radiation, maybe they got lost to follow-up, and now they show back up with a normal testosterone level, but advanced disease. One of the things that patients focus on all the time, as do physicians, regarding prostate cancer, is the biomarker PSA. And we know from many prior trials, whether it's in the castration-sensitive disease state or in castration-resistant, is that the rapidity of the rise of PSA, or oftentimes what we call PSA velocity or PSA doubling time, is a really excellent marker for understanding the biology of the disease. When patients have a really quickly rising PSA, certainly a doubling time of less than or equal to 10 months, less than or equal to 6 months, less than or equal to 3 months, this heralds invariably a very aggressive disease or proliferation of cancer cells, regardless of it being in the castration-sensitive or the castration-resistant disease bucket. Now, there's been some work over the course of time that's demonstrated to us why this is so valuable to calculate or think about, even if you do a back-of-the-envelope calculation of the PSA doubling time. Usually we think about this by calculating at least 3, possibly 4 PSA values over a period of a year to 18 months. And this allows us to get to this inflection point that has been very nicely described in earlier studies where we were looking at bone health agents. Very nice work performed by Matt Smith and others, which essentially showed us that the doubling time of 10 months or less correlates very significantly with a risk of developing metastases and or death. So this becomes a really nice way to sort of frame things for patients when you're thinking about when do I start a therapy. Well, let's talk about a patient of mine named Ron. And he's very emblematic of patients I see over the last 20 years. A pretty healthy, good performance status, 63-year-old man, working regularly. He's a high school teacher, teaches mathematics. And he's got a wife of about 30 years, and he has 3 children, 2 in high school, 1 in junior high school, middle school. He's active in the community. He enjoys playing golf, hunting, plays tennis, and keeping up with his family and traveling. His prior health is notable, and we see this sometimes for being slightly overweight, having some high blood pressure, a little bit of a high cholesterol level, and some lipid issues that he's followed for with his primary care physician. When I first met Ron, and he was diagnosed with advanced disease, he had an elevated PSA, he had a biopsy-proven prostate cancer, and ultimately he had signs of bone metastases. And one of the things that was particularly concerning to Ron, before he even asked me about his survival, was, is my pain in my back related to the cancer, or is it just related to the hobbies that I do? And we talked about that, and we talked about the importance of understanding what patients focus on. Now, some patients will say, well, I just want to live as long as I can, and some will say, I just want to avoid having consequences of my disease. I'm scared about having pain. I knew someone in my own family who had pain and had a really miserable life ending. I want to avoid that. And of course, I want to live as long as possible because I have a young family. And then there's just the anxiety of having a cancer diagnosis. The C word of cancer causes a tremendous amount of anxiety, understandably so. It's our job to make sure that we demystify for some patients who have less aggressive disease to some who have more aggressive disease. So in association with Ron's concerns about pain and longevity, we talked about his ability to continue to work, depending upon the therapies that we chose, how they would affect his ability to teach high school mathematics, do his activities, and his hobbies. So, you know, the notion that fear and anxiety is absolutely integral to a new diagnosis of cancer is obviously very intuitive to urologists and medical oncologists. Patients want to, they want to live longer, they want to maintain their performance status, or what we oftentimes call their quality of life, and they want to avoid complications of therapies. They're concerned about their energy levels, they're concerned about their cognition, they're concerned about effects of their cardiovascular health, they're concerned about their ability to just do daily life activities. And these are things and ideas that I think prostate cancer support groups are wonderful at addressing. Our nurse support groups are wonderful in addressing. Physicians can do a good job with it too, but we have to balance that with our time and our schedules in our clinics. So I've mentioned already what my goals are. Let me reshape them for you. I talk about 4 Ps, and prolong survival, prevent complications of therapy, preserve quality of life, and then preference value. So what's preference value? Preference value is how risk-seeking, how risk-averse are you? And you know, we all have these patients who come in and they may be somewhat nihilistic and say, you know what, I'm 70 years old, I'm feeling great, I don't want any kind of treatment. I don't want to, you know, take any medications or do therapies. Now, fortunately, that's a very small number, and we have to do our best to explain to these patients that we have really proactive treatments that will allow them to live longer and maintain quality of life. But that's a really risk-averse patient. You know, sometimes they read in the literature that, you know, everybody dies of prostate cancer or with prostate cancer, but will die of something else, and that we obviously recognize that misconception. And then we have patients who come in who have really poor ECOG performance status, and you know, they may come in a wheelchair on oxygen supplementation and are really incapable of receiving a lot of therapies, but the family says, no, you've got to, you know, pull out all stops. That's a group that is clearly risk-seeking. And I give you these extreme, somewhat hyperbolic examples, but it does make for the art of medicine and why it's important to know what the options are. So I met with Ron and his wife, and we discussed multiple treatment options. And their questions were, will he be able to continue to work? He needs to work. He needs the income. Will he continue to be a supportive and involved father? Will he continue to be able to perform the hobbies that he likes to do, golf, tennis, hunting? And how will we pick a treatment? How will we track the progress of that treatment? What are the goals of treatment? And I already talked about the goals, and it's a good question. Patients will frequently ask, well, how do we decide we're going to change a treatment? I talk about this as a sort of a three-legged stool, and everybody can do it differently. I try to simplify it, but not make it too simple. And in prostate cancer patients, I say, yes, we're going to follow the PSA, but we're going to follow all the lab work. We're going to follow hemoglobin, the red blood cell count, albumin, a reflector of nutrition. We're going to follow liver enzymes. We're going to follow bone enzymes. And so, of course, electrolytes, kidney function. So it's the lab picture. And if the labs are going in a direction we don't like, that's important to know regarding a treatment. Probably most importantly, I tell Ron and other patients is, what about your symptoms? Are you developing any new symptoms? How's your energy level? Are you developing new pain? Very, very important. And overall body systems, like we all do. And then third is imaging. And imaging is important because finding new lesions, documenting new lesions, new bone disease, additional bone lesions, additional soft tissue, lymph nodes, or if there is visceral metastases, development of disease into the liver, the lungs, occasionally the brain, these are all reasons and indications for considering another line of therapy or another line of treatment. And I like to get that discussion up front because I tell patients this will be a very long conversation. Once you have metastatic disease, I can't cure you, but we want to follow those 4P goals that I talked about earlier. So Ron, a patient of mine, he entered into a clinical trial. I really enjoy doing clinical trials. I enjoy it because this is how we answer unmet needs. Clinical trials are really recommended by all of the international guidelines whenever that option is suitable for patients and if you have the facility and the accessibility to do a clinical trial. Since 2010, we now have 9 new approved agents that are life-prolonging in prostate cancer. Prior to 2010, we only had 1. So isn't that a rather amazing accomplishment through all of the preclinical work and the work of our colleagues globally? So Ron entered into a trial known as the ARCHES trial. And I was involved in this trial. It was led by Andy Armstrong of Duke. And this was a global phase 3 trial that had a 1-to-1 randomization of over 1,000 patients who had low volume, high volume metastatic castration-sensitive prostate cancer. Essentially used the definition of low and high volume of 4 or more bone lesions was high volume, and one of those bone lesions had to be outside of the axial skeleton, in other words, an appendicular lesion. Or high volume could be any visceral metastases. Anything less than that was low volume. We also stratified patients based upon whether or not they'd been exposed or had received, before starting the study, taxane-based docetaxel therapy. And a really important trial because in this 1-to-1 randomization, and the patients continued on in both arms, they had testosterone suppression, an approved androgen deprivation therapy, and they would receive either enzalutamide, 4 capsules, 160 milligrams daily, or a control placebo. And we monitored these patients for radiographic progression. We monitored patients for their tolerability and for safety. And ultimately, what was the finding was we clearly hit the primary endpoint, and that was radiographic progression-free survival. Those results have been published. And the findings of the ARCHES trial have now been well established. We've established the findings based of the rPFS benefit, regardless of whether the patients had of a disease in soft tissue, a disease of bone, and clearly demonstrating the efficacy in the rPFS finding, the primary endpoint. We did another analysis, and this data was just recently presented at ESMO 2020, where we looked at the baseline PSA levels. And the patients in the therapeutic combination enzalutamide ADT significantly reduced the risk of PSA progression and the development of castration resistance versus the ADT placebo group, regardless of the baseline PSA in ranges of less than 0.2, 0.2 to 4, or greater than 4. And so I think this is a very significant finding in terms of how we measure the PSA kinetics. So other trials have been very, very important in playing a role in metastatic castration-sensitive prostate cancer. We sometimes call this metastatic hormone-sensitive prostate cancer, and we really have had what some might describe now an embarrassment of riches. So before I talk about other combinations, let me also tell you about the Enzyme Trial. The Enzyme Trial had two arms, but looking at ADT plus enzalutamide versus ADT and a first generation, or what some would call vintage androgen receptor inhibitors. And the most common one used in this study was bicalutamide. And patients were evaluated in a similar 1-to-1 ratio to see if there would be therapeutic benefit. Now, interestingly, in Enzyme, the primary endpoint was overall survival. Stratification factors looked at exposure to docetaxel, and it's an interesting use of docetaxel. And nearly 45% of the population received concomitant docetaxel during this trial. We looked at bone health agents, or the anti-resorptive agents, and comorbidities. At the end of the day, what was really compelling about the Enzyme trial, as opposed to the ARCHES, where ARCHES' primary endpoint was rPFS, the primary endpoint in Enzyme was overall survival. And in the intent to treat entirety of the population, the combination of ADT plus enzalutamide bested ADT plus vintage AR inhibitor, predominantly bicalutamide. So now we have two separate phase 3 trials combining ADT and enzalutamide, demonstrating primary endpoint success of rPFS and overall survival. So let's talk about other therapeutic advances in the landscape. And so the TITAN trial looked at a very similar, same population, low volume, high volume, nmCRPC, and randomized patients in a 1-to-1 basis of ADT plus apalutamide, another important AR signaling inhibitor, versus ADT and a placebo control. And in the TITAN trial with ADT plus apalutamide versus ADT and a placebo control, this trial was successful regarding its efficacy outcomes regarding both overall survival and progression-free survival. Another important trial that has just completed accrual is known as the Erwins Trial. Now, this trial looked at combining ADT docetaxel in both arms, two arms, metastatic castration-sensitive prostate cancer patients, and the trial essentially compared ADT docetaxel with or without darolutamide, a new AR signaling inhibitor that right now is only approved in non-metastatic castration-resistant prostate cancer. So triplet therapy versus ADT docetaxel. So let's get back to Ron. He is going to start testosterone suppression. He is going to start in the ARCHES trial an AR signaling inhibitor, enzalutamide. As we know, enzalutamide has been already approved since the 2012. Its initial approval in nmCRPC post-chemotherapy. That was the AFFIRM trial. Then we saw the PREVAIL trial, another phase 3 study that demonstrated the value of enzalutamide in pre-chemotherapy nmCRPC patients. Two large phase 2 trials looked at enzalutamide, known as the STRIVE and the TERRAIN, prior to chemotherapy. We then also have trials that I've just described to you for nmCRPC or MHSPC, ARCHES, and Enzyme, and I'm going to later on review with you the PROSPER trial, which led to the approval of enzalutamide in nmCRPC. In picking a therapy, what do we talk to our patients about and their caregivers? Well, I think it's really important to have that full-throated conversation. Otherwise, patients are surprised. And oftentimes that conversation has to be restated, perhaps by the physician, perhaps by the nurse care team as well. It's very important. Otherwise, patients get seemingly caught off guard. Now, looking at the ARCHES trial, and the safety data, what was really good to note was that overall we didn't see any new safety data or adverse events that were different from all of those other trials that I had articulated just a little while ago. So that's very important, I think, and gives us a lot of reassurance that enzalutamide had a tremendous global real-world experience. You can certainly see some increase in hot flash. You can certainly, and most importantly, see some fatigue issues. And there are some cardiovascular issues, as well as the occasional a concern regarding a fall and a fracture that one needs to be aware of. Similarly, in the TITAN trial, apalutamide hit its efficacy endpoints of survival and rPFS, and likewise had similar concerns and strategies that we always have to be thinking about relating to fatigue, loss of sexual desire, hot flush, cardiovascular implications, and even risks of falls and fracture. And in apalutamide, another signal, it doesn't happen very frequently, but it's somewhat unique, is a rash phenomenon. So the take-home messages when I was having the conversation with a patient such as Ron and his family is, you've started the therapy. It's a combined therapy. It's combination therapy. And I think that's a really important take-home for my colleagues, is that monotherapy testosterone suppression, just using ADT, is really not the standard of care anymore. We have data from Charted, Stampede, Latitude, which looked at abiraterone acetate, high-risk patients. We have data now from Enzyme, from Arches, from Titan, which clearly demonstrates that combining therapies with ADT and an AR inhibitor is better than monotherapy ADT. And that's a very, very important take-home message. And I further continue to dialogue with patients such as Ron, the importance of maintaining good nutrition. Many of us are suggesting that it should be more of a plant-based diet, a Mediterranean-style diet. I certainly try to encourage patients to think about taking ownership of that particular nutritional aspect of their life, and exercise to ward off some of the fatigue issues. A lot of new data suggests that directed exercise, in other words, help getting your exercise, keeps a higher level of fidelity and better muscle mass development, as well as better cardio fitness, aerobic fitness. One of the things that comes up very frequently is when patients then go on to develop what's described as castration resistance. So going back to what we were talking about at the beginning of our presentation, we have patients who present with de novo metastatic disease, low volume, high volume, or they develop metastatic disease after they've failed surgery or radiation. But for the patients who have had surgical intervention or radiation treatment, and unfortunately they get PSA relapse, and the PSA change over time is concerning enough that a decision is made to start androgen deprivation therapy. And there's some subjectivity to that, doing the risk-benefit analysis, but a decision invariably does get made, and the PSA comes down. But then invariably, the PSA will start to go up. It's important to check a testosterone level to ensure that T suppression therapies, androgen deprivation therapy, is being administered appropriately. Patients are responding appropriately. So I really stress the importance of not only looking at the PSA at this point, but also the testosterone level, making sure its levels less than 50 nanogram per deciliter. Conventional imaging is obtained, and if the patient has a normal CT scan, a normal technetium bone scan, then what does that herald for the patient? Well, prior to just a couple of years ago, we didn't have any level 1 evidence for patients with nmCRPC that they could benefit. And lo and behold, we now have 3 trials that have demonstrated not only a delay in progression of disease, but most recently in 2020, we can now say prolonged survival, and I'm going to talk about those studies in a minute. So John, much like Ron and other patients similar to him, We think about their age, we think about their family dynamics. Is the patient still working? What kind of work does he do? What are his lifestyle activities, his hobbies that are important to him, and his other health comorbidities? So John and I sat down with both him and his wife, and we talked about what are his options now that he has a rising PSA, testosterone level is suppressed, and why would we even choose a therapy? Because his symptoms are just consistent with the duration of his T suppression. And so patients see the PSA going up, and that causes some anxiety, and they want to know, well, the scans are negative, doctor. The CT scan, the bone scan's negative. I'm not getting any new symptoms. No one gets symptoms from a PSA elevation. Why are we going to do a treatment? Well, the answer is these three outstanding studies that have just come to our attention in the last couple of years. And I'm going to talk now about these three trials, the PROSPER, the SPARTAN, and the Erwins trials. The PROSPER trial was a 2-to-1 randomization, patients receiving enzalutamide versus a control placebo in nmCRPC patients, or what we used to call M0-CRPC patients. SPARTAN was an identically designed study, but instead of comparing with enzalutamide, it looked at ADT plus apalutamide, and in the control arm was continued ADT and a placebo. The Erwins trial, similarly designed 2-to-1 randomization, nmCRPC patients, but looked at the AR signaling inhibitor darolutamide. With all three trials, the primary endpoint was metastasis-free survival, which is a co-primary review of radiographic progression and or death. And the eligibility criteria for all three were very similar. Rising PSA, had to have a PSA doubling time of less than or equal to 10 months, had to have an absolute PSA of greater than 2, and had negative findings on imaging, obviously. And here I can tell you about how these studies have, I think, really reshaped the landscape for nmCRPC. Because prior to 2 years ago, we had no level 1 evidence that there was any benefit to regularly starting a patient on therapy until they developed imaging positivity. And now I can tell you that we have 3 trials that hit their primary endpoint of metastasis-free survival, all with clearly positive findings on their Kaplan-Meier curves, all with statistically significant findings. One of the things that patients would say as well, you're going to delay the onset of the disease, and many of my colleagues would say, but is it going to really affect survival at the end of the day, or is this just going to be a lead time bias as it's described? And what came out this year in 2020, data presented both at ASCO 2020 and ESMO 2020 was, yes indeed, we now have secondary endpoint of overall survival in all 3 trials. And all 3 trials have hit the overall survival benefit. And I think this is just another wonderful example of how we can augment patient decision-making and therapeutic selection for patients. All 3 are oral medications, and all 3 have some new side effects that one needs to be cognizant about. But certainly if you can tell a patient your PSA is going up, you've now somehow developed, we understand there's a lot of different mechanisms, whether they're AR driven or other pathways of molecular aberration, which we're doing a lot of continued working and review druggable targets. But looking at the AR target, we now have 3 medications that have demonstrated level 1 evidence, category A. They've been incorporated into the guidelines, NCCN, ESMO, ASCO, AUA, that basically say when you have a rising PSA, castrate level of testosterone, negative findings on conventional imaging, you now have 3 different oral medications to choose from to not only delay metastasis, but also to prolong survival. So we talked about these adverse events, and there are, for sure, there's no free lunch, and anytime we add another line of therapy, we have to be cognizant of cardiovascular effects. And so the world of cardio-oncology has become very important to us all to become better stewards of treatment selection and management, and even neurologic oncology. How are patients tolerating these drugs in terms of the neurological spectrum? Fatigue, depression, cognition. And then, of course, as I mentioned earlier, the importance of nutrition and directed exercise. It's important to look at the differences and the nuanced differences in the adverse events that have been reported in all three of these trials. All three studies had New England Journal publications. And you can review, and I encourage you to review, the different adverse event differences. We don't yet have direct prospective comparator trials. I think those will be forthcoming, and they'll be very important to be aware of. So in summary, John starts nmCRPC, and particularly here, he was started on enzalutamide, 4 capsules once a day with or without food. His PSA plummeted. He had the ability to continue to do all of the things that he likes to do, which I think is so important to our patients. We see the PSA go down, but more importantly than the PSA going down, which is a big focus of the patient and family, is knowing that on average, the median time to development of metastasis in PROSPER, in ARAMIS, in SPARTAN was about 2 years. So a near, on average, 2-year delay to the onset of radiographic progression. And then all three trials now demonstrating a year to slightly more than a year benefit in overall survival, when all three trials had crossover and patients had the ability to get other life-prolonging agents in both arms. It doesn't take too much to recognize that this would really very, very positively impact a patient's quality of life who has a terminal disease, assuming he doesn't succumb to something non-related to the prostate cancer. So we have other things that we're working on today, other really great advances, for example, PARP inhibitors. These PARP inhibitors work on a subset of patients who have what is described as homologous recombinant repair mutations. It's really important that we all recognize now through our experience with our medical oncology colleagues who've been looking at genomic profiling in patients with metastatic breast, ovarian, and pancreatic cancers, that these homologous recombinant repair mutations of genes, and it can occur in about 25 to 30% of our nmCRPC patients, can benefit now from PARP inhibitors. The FDA approved 2 new drugs for our nmCRPC patients who have progressed on gene alterations, most commonly BRCA2, BRCA1, and also for olaparib, there's an additional 14 gene panel. And these are patients with nmCRPC who have progressed after a novel hormonal agent such as abiraterone or enzalutamide. Rucaparib is also approved for patients who've progressed on a novel hormonal agent and taxane-based therapy. We have many other trials that are ongoing with other PARP inhibitors. The class will have competition, and that's a great thing. Just like the AR signaling inhibitor class does, we'll see competition throughout the PARP inhibitor class. So I go back to the notion around how do we optimize care. One of the things is we're getting very, very busy and very, very complicated, and genomic profiling, a slew of therapeutics depending upon where you are, mCSPC, de novo, recurrent, biochemical relapse, non-metastatic CRPC, and now nmCRPC, multiple lines of therapy. And so understanding and working collegially in a multidisciplinary and in a multi-professional way with all of the healthcare providers involved is absolutely essential. We have to do our best to make sure that patients get access to as many life-prolonging therapies as possible. Data clearly suggests that patients do much better if they get more than 1, 2, 3, 4 therapies, as long as they're optimally enrolled. and decided upon. So, one of the things that I've really been very proud to be part of are the patient advocacy groups. And organizations such as PCEC, US2, FEN, really provide a wonderful opportunity, and I haven't mentioned all of them. These patient advocacy groups do yeoman work to help provide patients and their families with educational support, with access to clinical trials. They raise money for research, and they really provide a very valuable, needed service. And it's globally as well. Europa Yomo does a great job, and every country has its individual advocacy groups. Super important. They make healthcare providers' jobs that much easier. So the Prostate Conditions Education Council, years ago, we actually, and I have the honor to have been part of the board, we called it the Prostate Cancer Education, but we morphed it over to conditions because there are so many other aspects to prostate disease and prostate conditions. So we focus now on cancer, early detection, prevention, health conditions, inclusive of non-cancer related aspects. A really great organization that provides a lot of patient education, and they are truly committed.
There are many resources that help me in my education of prostate cancer disease and treatment. There is a lot of material that is out there, but it is somewhat of a struggle to integrate it all together and know exactly where to go for some of that information. A lot of it can be extremely technical and takes a long time to sort through some of the technical jargon that's there. But there are many places that information can be obtained. And I will identify that PCEC is one of those locations that does have very good resources that they identify. It talks about the prostate cancer disease itself and also some of the treatment options. One nice thing I like about PCEC website is that it doesn't talk down to you. It has enough detail in there to give a person that's somewhat educated on the disease even more information, yet it is not so deep that you have to go get your medical dictionary and read what some of the words are. So they actually have a very nice format associated with that. Physicians have an important role, obviously, not just in the treatment of the disease itself, but also helping the patient with education and understanding the disease itself and the nuances of that disease. But there are a lot of resources that are out there, and it is sometimes very difficult to find them, or if you do find them, to cull through that. It is enormously time-consuming. I frequently feel if the physician could narrow down some of the resources that are available to the patient, that would be tremendously helpful to the patient.
So with that, it's been a great pleasure for me to review all of this data that has been forthcoming in the last few years. It's really put things in a different perspective. I would just say, if you have someone who has metastatic hormone-sensitive prostate cancer, newly diagnosed or recurrent, monotherapy ADT is no longer your only choice. There are combination therapies that are clearly essential to be reviewed, have to be reviewed with patients. And then similarly, patients who have non-metastatic CRPC, we have 3 new alternatives to advance these patients' survival and prevent a progression of disease. Thank you very much.
This activity has been jointly provided by Purdue University College of Pharmacy and PVI, Peer Review Institute for Medical Education.